A warm Good evening, everybody. A warm welcome to everyone on behalf of ISA Kalyan. Shall I share the screen? Okay. Good evening, everyone, once again, and warm welcome to all on behalf of ISA Kalyan. I invite and welcome our most helpful and inspiring Honorary ISA National Secretary, Dr. Naveen Malhotra. I invite and welcome Dr. Anjali Bhure, Madam, ISA National Vice President. I invite and welcome Dr. Ashok Deshpande, Sir, ISA National GC Member. Maharashtra State President, MIXA President, Dr. Manisha Kartikar, a warm welcome. She has been very inspirational and extremely helpful and progressive. Warm welcome to Dr. Avinash Bhosle, a very enterprising MIXA Secretary. Maharashtra State Vice President, Dr. Anita Nehete, a warm welcome to you. Dr. Hanuman Saleh, Sir, President-elect Maharashtra State ISA, a warm welcome to you. ISA Kalyan invites and welcomes Dr. Samir Sohani, Honorary Treasurer, Maharashtra State ISA. Dr. Hemant Shinde, the MISA News Editor, a warm welcome to you, sir. Dr. Milind Pol, Immediate Past President, Maharashtra State ISA, warm welcome to you, sir. I welcome all the Maharashtra State ISA branch president and secretaries who have joined, all the dignitaries, all my teachers, seniors, friends, and colleagues. Dr. Smita Shah, Madam, ISA Kalyan President, I hand over to you to continue further.
Thank you, Kala. Good evening and once again warm welcome to all of you. Today my happiness has no bounds and I am overwhelmed by the presence of all our seniors, my colleagues, my juniors and all dignitaries from state and national ISA board for the most awaited event of our release of second edition of e-bulletin Samohini and our journal club presentation. We all know that as we sow, so we reap. So the first foundation of this big tree of ISA Kalyan was laid as NSSA, that is North Suburban Society of Anesthesiologists in 2009, with president as Dr. Lokras and his team. All committee members in every tenure worked selflessly, dedicatedly, without any remuneration and publicity for upliftment of this organization, and it became ISA Kalyan in 2017 under presidency of Dr. Kolvekar and team. Till now, 50 CMEs on different topics, hands-on workshops, BLS and SLS activities, COLS activities for public awareness and public awareness program were conducted. Myself and my dynamic secretary, Dr. Kala, and my all executive team members, we all together conducted 4 CMEs and JC presentation in and all our enthusiastic members participated in these virtual cultural programs on the Diwali, Navratri, Ganesha festival, and even Valentine Day celebration. We started YouTube channel and public anesthesia awareness program for lay people. So now I express my gratitude from bottom of my heart by welcoming all my seniors, Dr. Lokras sir, Dr. Nitin Chitnis, our past president, Dr. Kolvekar, then Dr. Chandan Singh sir, Dr. Amita Kulkarni madam, Dr. Kuntambekar, Dr. Vishwas Sathe, then Dr. Mandar Tatke, then Dr.
Ma'am, please unmute yourself.
Hello. Was I audible till now?
Yes, ma'am.
Yeah. Sorry. And all by Dr. Kala Ishwaran and my present executive members. And and I say Kalyan family members, and on the occasion of release of our second edition of Samoin. I hand over to Dr. Kala madam to carry forward the session.
Yes. Thank you, Dr. Smita. I welcome Dr. Manisha Kartikar, Dr. Avinash Bhosle, Dr. Saleh, Dr. Nihite, Dr. Sohni, Dr. Hemant Shinde, and Dr. Milind Paul to say a few words. Dr. Kartikar, madam.
Thank you, Dr. Kala, madam. It is always pleasure to be on the platform of ISA Kalyan, and I'm really happy to see the release of second issue of Samohini. I had witnessed the release of the first issue. Kala, madam, you mentioned me as a progressive, but I can see how Kalyan branch has progressed in last 3 years. I'm sure Kolvekar sir, the founder editor, must be very happy with your progress and with the way the Kalyan branch is doing wonders in all these ISA activities. Respected Naveen Malhotra sir, it is always a pleasure to welcome you on the platform of Maharashtra State Chapter ISA, whether it is a virtual or physical. Welcome, sir. Hoping to see you soon physically in one of the conferences in Maharashtra. Very soon, in fact. Welcome, sir.
Thank you so much, Dr. Manisha, madam. Will anyone else from the Maharashtra state dignitaries want to say a few words? Okay. I'll hand over to our GC member,
Hello.
Dr. Yeah. Yes.
I will talk after the release of your bulletin.
Bulletin, sir. Okay, sir. No issue. I'll invite Dr. Preeti Nanda, our GC member, to invite and welcome Dr. Naveen Malhotra and give his introduction. Dr. Preeti.
Good evening, everyone, and welcome all the dignitaries. Welcome to ISA Kalyan branch. I'm very fortunate enough to be introducing this dynamic honorary secretary of our national body of ISA, Dr. Naveen Malhotra, who is a revered senior professor in anesthesiology and head of pain management center of PGIMS, Rohtak, and has received several awards. Mentioning few is the ISA Bhopal Award for Academic Excellence in 2015, KPR Young Anesthesiologist National Award in 2009, and whooping publications of 195 with presentations up to 392. He has very beautiful original work of submentotracheal and retromolar intubation, which we will maybe invite him someday to talk on. And he's our current honorary secretary of ISA national body. Welcome, sir. And I'll hereafter ask Prasanna sir to continue.
Thank you, Preeti. Thank you, Kala, and everybody. Good evening, everybody. Am I audible?
Yes, you are audible.
Okay.
Please continue.
So just to ISA Kalyan has been publishing this local edition of Samohini. It's a small bulletin which initially used to be in print format, and almost after I think 2011 or so, we started publishing it only in soft format. And this is for information of the delegates all over the state and national delegates, plus the few new members who have joined Kalyan family. So this bulletin usually is a academic plus non-academic contents which we try to gather from the family, the Kalyan family, and we publish them for our local circulation. Basically, through this bulletin format, we have published first aid manual, then the operation theater safety manuals, which were quite useful, and they were implemented for quite a long time meanwhile at all our operation rooms, and we had a very good scenario everywhere. Now we feel that it needs some upgradation or updating those standards, and very soon we will be coming up with those sort of guidelines or printed format of bulletins, and that we will circulate in our area to the hospital owners and the nursing homes, where we can have some good standards. This bulletin usually is very interesting. Many very new ideas or new informations we have received from our colleagues. People have been more very much creative also. Their literature or poems and their articles, they are definitely worth reading many a times. So this bulletin, Kolvekar sir and Dr. Gaikwad, she has taken a lot of efforts, and they have done enormous work to make this e-bulletin, make it into a reality. So everybody will be eager to see that, I hope so. And very soon sir will present this bulletin to everybody. So I hand over this to Kala for further proceedings.
Dr. Malhotra, will you want to say a few words, or should we go ahead with the release?
Good evening, everyone. The presiding officer of today's ceremony, Dr. Smita Shah, the Honorary President of ISA Kalyan Branch, Dr. Prakash Deshmukh, Vice President, Dr. Kala is the Honorary Secretary, and I must say, I profusely thank you for the warm invitation and the follow-ups. You ensured that I am here today amongst all of you, and your president has very rightly said that you are a dynamic secretary, and you were talking in your introduction that you get inspired from me, but I must say that I also get inspired from you and your NLP individually. I've seen you at multiple platforms, and I was very eager to join Kalyan branch. So you were a bit skeptical whether I will join or not, but I really want to interact with all my members. And as Madam Priti Member gave a very fond introduction, the only thing that in the achievement, which is not projected, she talked honorary secretary. No, I am not honorary secretary. I am your secretary.
Thank you.
That's your big-heartedness and humbleness, sir. Thank you so much for joining us.
Somebody asked me, what are your areas of interest? So I said, clinically, my area of interest is chronic pain management. But otherwise, my area of interest is to make friends and win hearts. So I'm really very thankful to all of you for the warm invitation. I must place on record deep sense of appreciation for the good work done by ISA Maharashtra, led by very dear, very respected Dr. Manisha Katikar, President, Dr. Anita Nehate, Vice President, and dear Dr. Avinash, Secretary. Actually, to be honest, I'm in mixed emotions. I am remembering I was just looking Dr. Shinde, editor. I was remembering my editor, Lalit Bhai. Dr. Anumat Saleh, the President.
Thank you.
Dr. Sohani Perar, immediate past President. And very happy to note your acknowledgement of the past presidents, Dr. Lokas, Dr. Nitin Chitnis, Dr. Kolvekar, and other dignitaries. It is always better to remember your seniors who have taken ISA forward and to new heights in your own city also, and in the state also. And yes, definitely, last but not the least, my members in the governing council from Maharashtra, Dr. Ashok Deshpande and very dear Dr. Anjali Rakesh Guru. It's a pleasure for me to be present here, interacting with you all and inviting me to release the issue of Samhoni. I really appreciate the work done by the editorial board. And yes, I've gone through it, a brief of it, that there is lots of activities mentioned about World Anesthesia Day, BCLS, CLS, about the Journal Club, CMEs, there are pictures also. And most importantly, there are articles on pain medicine also. So, and look forward to more such issues in near future from ISA Kalyan. My heartiest congratulations to Team ISA Maharashtra and Team ISA Kalyan for the wonderful work. It's a pleasure to be here inaugurating this issue of Samhoni.
Thank you so much, sir. Shall I go ahead with the next?
Yes.
Shall I release it, sir?
So I hereby digitally release the e-bulletin of ISA Kalyan Samhoni. Heartiest congratulations.
This is the second edition, Sammohini. Shall I stop the screen sharing for some time and go to the PDF, sir?
Yes, please.
This is our Sammohini, sir. I will like Dr. Kolvekar and Dr. Revati to come forward. And shall I
Thank you, Kala. This is a joint effort, and many members of ISA Kalyan contributed to this Sammohini, and we are seeing never before kind of development virtually, physically, and in publications also.
this is our contents. World Ether Day celebrations all over the town, sir. Calls and BLS activities were done everywhere. You can see the numbers. All of them have participated enthusiastically. Then other academic activities, sir, we have had 4 journal club meetings where we do our how do I do it video sessions by our members, and journal reading is done thoroughly. The CMEs were conducted on maternal collapse. Then on 20th November, pediatric CME. 8th December, we had ICU in the OT. I mean, the emergencies in the OT. We have medical equipments from Torrent, and we had published the guidelines to perform pre-anesthesia evaluation and maintenance of anesthesia records. This e-bulletin will be distributed all over the small nursing homes across the ISA Kalyan, so that our counterparts, the hospital owners and the surgeons and gynecs, download this and maintain ISA uniform record sheets, so that there is uniformity throughout all the areas of ISA Kalyan. This has been nicely compiled by Dr. Kolvekar and Dr. Revati. Hats off to them for their relentless efforts. And this is an article by Dr. Prakash Deshmukh, who is our pain consultant. and newly entered pain consult area is Dr. Swapna Dahivadkar. She has written her journey from being an anesthetist to a pain consultant. Beautifully written article, which might be inspiring to many others. And we have celebrated many festivals together, the Navratri festivals, the Diwali, Dashera, and Republic Day, the Valentine's Day, the Christmas, Makar Sankrant, everything. We released 2 YouTube channel videos on public awareness. And Rangolis by Dr. Sanjot Abhade for every occasion. Such a beautiful creativity by her. I mean, such a beautiful creation. You have to go through all this. Wonderful, madam. Thank you so much, everyone, for patiently going through our e-bulletin, Sammohini. Dr. Avinash, sir, you wanted to say something?
Yeah. Respected Dr. Naveen Malhotra, sir, Secretary, ISA National, all office bearers of Maharashtra State Chapter, then all office bearers of Kalyan, ISA, and all dignitaries, guests, faculties, today's delegate, and all ISIans and my friend. Very good evening. Today I am so happy to see that many of our city branches are releasing their own city branch e-bulletin or magazine. Actually, this e-bulletin or magazine is not only an academic book, but it also reflects your work done. So already all of you have seen that how many activities were done by the ISA city branch. It also remains as our memory book. So I congratulate ISA Kalyan branch and their office bearers, the editors of the e-bulletin सम्मोहिनी. मुझे आशा है कि ये सम्मोहिनी सबको मोहित करे और सब अदर सिटी ब्रांचेस को भी सम्मोहित करेगी और they will also think of releasing e-bulletin like this सम्मोहिनी. I wish it will be circulated all over India and sure it will be appreciated by all. Thank you very much for inviting me. I wish best wishes to the CME also. Thank you. Long live ISA. Thank you. Thank you very much.
Thank you so much, sir. That was very nice, kind words for ISA Kalyan. Thank you so much. I invite Dr. Kolvekar to say a few words on Sammohini. He is the chief founder editor. Kolvekar, sir.
Yeah. Thank you, Secretary Kala. This started long back. You know, we started NSSA way back in 2009, and from there we used to, you know, like make this as a hard copy. And I used to send myself with the help of Dr. Kuperkar. We used to courier it to our members. You know, we used to, you know, print on a home printer and, you know, like staple it, put some tape on it, and we used to send it. And people used to read it. And it, as Dr. Bhosle said, this thing, you know, gives a platform for our cases and new technology, the recent updates, as well as the talent of individual members. Like you have seen Dr. Sanjot Avade's art, and a lot of people, you know, they send poetry, they send their own articles. We have had published, you know, like Marathi literary, you know, like poetry and some write-ups, travelogues. Dr. Prasanna had sent a traveler. He's an hiker as well. So, it makes it a very happy family kind of thing, along with some updates, knowledge, and that puts in a lot of enthusiasm in the members. The activities done, the CMEs plus the COLS thing. So it makes a good family friends, and you would be happy to know that every year we have celebrations and get-togethers, fellowship programs, dance, singing, and all. Dr. Kala, she's a good dancer, and Dr. Rajkumar with his guitar is a great singer. So we are a family, and when we work as a family and we promote the talents of our members, we work well as well. So is a happy family, is a successful family. So thank you.
Thank you so much, sir. I'll invite the young dynamic editor, Dr. Revati Gaikwad Khernar. Revati, would you like to say something? She's 6 months pregnant, madam. In spite of that, she has done a wonderful job of editing. Thank you, Revati.
Thank you, madam. Good evening, all. It was really a wonderful experience working for ISA Kalyan and editing this magazine. This was a second issue of our e-bulletin, and we are very fortunate that we have the release at the hands of Dr. Naveen Malhotra, sir. Thank you, sir, once again. I take this opportunity to thank all the contributors and authors for providing me with a very good content, without which this compilation would not have been possible. And I hope that I appeal our members to continue giving such support so that we can see the release of Sammohini on a very regular basis in future. Thank you.
Thank you. Shall we conclude the release session, sir?
Yes, you can proceed for the next.
Yeah, then I'll just thank. I would like to thank all the sponsors and thank you all the dignitaries and all the participants of being present here for the release of our Sammohini e-bulletin. And I thank all the sponsors. Yeah, I thank all the sponsors, that is Torin, the Troika, and Varenium, who have been contributed towards this Sammohini. Thank you all. Now we proceed further for our journal club meet. Dr. Abhade, our journal club in charge, will take over from here. I invite Dr. Naveen Malhotra to give his presentation on anesthesia. Dr. Abhade, you can take over from here.
Thank you, Kala. Good evening, all of you, and a warm welcome to Journal Club presentation. It's nice to meet you all again on the JCP platform. We have another interesting article for JCP today: comparison of transforaminal and interlaminal epidural steroid injection for the treatment of chronic lumbar pain. There is a Buddhist proverb, pain is inevitable, suffering is optional. Yet another proverb by Saint Augustine, the greatest evil is physical pain. While chronic pain may be unavoidable, it can be devastating, causing substantial suffering and affecting the quality of life. It is also a heavy burden for the society, including resources for sick leaves, disability treatment, healthcare costs, and productivity loss. And hence, therefore, it requires special attention. Pain relief has always been our motto, and so the onus falls on us to offer some solution for this problem. As we are aware of the complexities of pain, it becomes important to have amongst us pain physician trained in orchestrating a unique treatment plan to achieve the desired goal. So today we have Dr. Naveen Malhotra, sir, as well as Dr. Kailash Kothari. So Naveen Malhotra, sir, wants to speak on chronic pain.
Ma'am, it's a brief. I'll just speak from my heart. It's not a presentation.
Okay, sir.
understand that this is a journal club, and it's pleasure to interact with Dr. Kailash Kothari, the president of Indian Society for Study of Pain, and the academics will be conducted by Dr. Prakash Deshmukh and other colleagues. So I just want to say that Dr. Kailash will agree with me that anesthesiologists are leader in pain medicine in India. There are other specialties also who are doing chronic pain, but I am very happy to share that we, the anesthesiologists, are leaders in pain medicine, and Dr. Kailash and Dr. Prakash will agree with me. Whether it is teaching, training, the abundant clinical work, basic to advanced interventions, research, and social and financial appreciation. The pain physicians, the anesthesiologists, they have built their careers exclusively in pain medicine and are doing wonders as by relieving pain of the patients, whether they are suffering from cancer pain or non-cancer pain. And there are new academic avenues also coming up in the form of, there are lots of teaching avenues in India. And the recent one is starting off dedicated 2 years course exclusively for anesthesiologists by the National Board of Examinations by the name of FNB in pain medicine. And as a convener of Specialist Board of Anesthesiology in National Board, I was closely associated with starting this course. And I'm very happy that this year in NEET super specialty examination coming up in June, the entrance exam for this FNB pain medicine, the 2-year course will be there. And the COVID pandemic has also thrown up numerous challenges. But anesthesiologists, in addition to taking care of COVID patients, they ensured that the chronic pain services are not interrupted. In the first phase, there was some interruption, but subsequently, the chronic pain patients were taken good care. There were numerous guidelines, practice guidelines by ISA and ISSP, especially on chronic pain management, which were very useful to all the chronic pain physicians across the country. Whether it is the newer avenues like telemedicine, the pain physicians have adopted that also with open arms to the benefit of the patient. So I reiterate by saying that anesthesiologists are leaders in pain medicine in India. And I congratulate Dr. ISA Kalyan for organizing the first journal club on pain medicine itself. Thank you.
Thank you, sir, for giving us complete information of how an anesthesiologist can be transformed into a pain specialist. Now, I take on the behalf of ISA Kalyan the privilege to introduce Dr. Kailash Kothari, sir. Kala, will you like to share? Yes. Thank you, sir, for being here with us today evening and being the chief moderator for today's Journal Club presentation. Dr. Kailash Kothari, sir, is the president of Indian Society for the Study of Pain. He has more than 20 plus citation to his credits. He has been on important position like council member, editor-in-chief, Indian Journal of Pain as a secretary. He is honorary pain management consultant at KM Hospital, Mumbai, spine and pain management consultant at Global Hospital, interventional pain consultant at Fortis Hospital, Mulund, and he is also a director for Pain Clinic of India Private Limited, Mumbai, ranging right from Chembur, Mulund, Bandra, Andheri, Borivali, Kalyan, and the list goes on and on. And he mainly focuses on treatment of spine conditions like slip disc, facet joint pain, complex regional pain syndrome, failed spine surgery pain, cancer and neuropathic pain, trigeminal neuralgia. Publications, editorial Modern Pain Management, USG versus Fluoroscopy in Indian Journal of Pain. He is MD Medicine, that is anesthesiologist and pain management. He has done it from 1988 to 1997 from Rural Medical College, Pune. We will be eagerly waiting for you to give your inputs, views, and ideas and comments on our today's presentation in the Journal Club presentation. We begin our Journal Club presentation today with Dr. Swapna Dahiwadkar. Swapna, can you share your slide? She is a senior consultant from Kalyan. She has done her MD from BJMC Pune. She's ex-assistant lecturer from KM Bombay, ex-intensivist from Singhania Hospital, and currently a freelancer doing mainly neuro anesthesia and pain management. She'll be telling us the transition of anesthesiologist to a pain physician. Then, to meet the unmet needs of our profession and offer a quality of life to those in pain, we have with us our own member, Dr. Prakash Deshmukh. He is a senior anesthesiologist and pain physician. He has done his FIPP, that is, Prakash, will you share your slide, or I'll read it?
Yeah, you read it.
Yes. Okay. He has done his FIPP, that is Fellow of Interventional Pain Practice from Budapest, Hungary. He is also FIAM, Fellow of Indian Academy and Pain Medicine. He is Executive Director, Pain Clinic of India from Kalyan and Andheri branches is attached to. He is Honorary Pain Consultant at LTMM College and LTMG Hospital, SAN. He has poster presentation on Spencer grasp, a new sign of complex regional pain syndrome, a case series in IASP, that is International Association for Study of Pain Journal, and ACTA Scientific Journal. Clinical perspective on neuropathic pain and use of lidocaine 5% patch with hydrogen technology in post-herpetic neuralgia. His note in the Indian Journal of Pain in August 2021. He is Honorary Vice President of ISA and he is past Secretary of ISA. And today he is going to present an article on chronic lumbar pain, treatment with epidural steroid injection, a comparison between transforaminal versus intralaminal approach. And followed by that, here in our How I Do It video session, Dr. Prakash is also going to show us interesting videos on sympathetic block and vertebroplasty. I hand over now to Dr. Swapna Dahiwadkar for her presentation. Dr. Swapna.
Before that, I would like Dr. Kailash Kothari to speak few words. Sir.
Okay.
Thank you, Kala. It's long time I'm seeing you, and that too online. And
yes. Even I did a stint on pain. I did course with you.
And it's fantastic.
You're my guru in that, sir. I still treat trigeminal neuralgia patients.
Yeah. I know many people tell me from Kalyan and all. So thank you, Dr. Navil Malhotra. I'm grateful that I am sharing stage with you now here, at least online, and we'll soon meet in Bhubaneswar. And thank you for kind introduction. And it is fantastic evening today with a very good program on pain management with my own colleague, Dr. Prakash Deshmukh and Dr. Dahiwadkar. And definitely, as I agree to whatever Dr. Naveen Malhotra he has said, and I must congratulate him for whatever he has done for pain medicine in India. And he has taken pain medicine to a different level by his contribution, not only at DNB level, but also at the government of India level. And he tried to get the recognition for the pain medicine at each and every level, wherever it is possible as a secretary of ISA. Thank you very much. And I hope that you are going to do a lot of work for ISSP in future as an office bearer of ISSP. And for anyone interested in pain management now, we have, as he rightly said, that we have a lot of avenues to learn how the pain management can be practiced, procedures, medical management, every aspect of, we have huge amount of teaching faculties and seats and different examination right from DNB. ISSP has their own fellowship program like Indian Academy of fellowship program, Indian Academy of Pain. So I think anybody interested, they can always connect to me or Prakash or anyone. And I congratulate ISA Kalyan branch, and I hope that we keep talking on pain whenever the opportunity arises. Thank you very much, and thank you. Nice to see you, Naveen. And let's begin the program.
Yes.
I'm eager
Thank
to
you.
hear everyone.
Yes, thank you so much, Dr. Kothari. And I will also welcome one of our mentors have joined. We had kept 4 mentors to guide us for journal reading. Dr. Soma Ganesh is also here. Soma, warm welcome to you. Over to you, Abhade madam.
Yes, we'll start with Swapna Dahibadkar.
Am I
Yes,
audible?
yes, you're audible.
Okay. Good evening and warm welcome on behalf of Journal Club presentation, ISA Kalyan branch. A special thanks and regards to Dr. Naveen Malhotra and Dr. Kailash Kothari, all the office bearers and ISA Kalyan family. I'm Dr. Swapna, presenting you with transition from anesthesiologist to pain physician. Transition is a change for betterment. Why anesthesiologists wanted a change or transition? They wanted to come in front from behind the scene and be in direct contact with patient as a super specialist. For last 5 decades, tireless efforts of anesthesiologists had made a new branch in medical field, the pain medicine, successful. It's like a proud mother anesthesiology looking at a fast progressing son, pain medicine. Pain is the most common cause of seeking medical care. Due to change in the lifestyle, food habits, also due to increased incidences of trauma and accidents, incidence of pain is increasing. Increasing lifestyle, increasing the life expectancy has increased the duration of pain. So we have to deal with a long duration pain that is a chronic pain. Chronic pain is a pain which is lasting more than 3 months. Grossly, it is divided into chronic primary pain syndromes and chronic secondary pain syndromes. In the primary pain syndromes, the definitive cause or source of pain is not known. That is, for example, fibromyalgias. And in the secondary pain syndromes, a definitive cause can be identified. For example, neuropathic pains, musculoskeletal pains, cancer-related pains, so on and so forth. IIPM has divided chronic pains into 7 categories, which I am not going to go in details. So why we are so worried about the chronic pain? Let's see. Chronic pain gives the ketophobia, that is to the patients. There are sleep disturbances, daily activity is hampered. So they have a psychological effect of all these things. These patients are frustrated, they get angry very fast, they are depressed, anxious, they lose their self-esteem. All these things results in the social consequences, like they have hampered relationship with the spouse, family, friends, also in the workplace. They always prefer social isolation. All these makes the patient disabled. There is loss of work days and healthcare cost increases. Here the pain physician has to play a very important role. When a patient comes in the OPD, he has to listen patiently to the complaints. He examines the patients thoroughly, rules out red and yellow flags, takes the help of relevant investigations and comes to the conclusion. Then the treatment modalities, either conservative or the procedural modality. In conservative modalities, pain physician gives a lifestyle change. He does the rehabilitation with the help of physiotherapist and of course drug treatment. If we decide for, say, procedural treatment, the term coined is MIPSI, that is minimally invasive pain and spine expectations, in which therapeutic and diagnostic blocks are performed. Diagnostic blocks are performed when one is not sure about the origin of the pain. For example, if a back pain patient comes and you are not sure whether the pain is originating from the disc or facet joint or muscle or anywhere else, then you target a most common area and give a diagnostic block. If the patient feels relieved by that, then you go for a definitive therapeutic modalities like radio frequency ablation, or you perform chemical neurolysis along with phenol and alcohol, adhesiolysis with saline and steroids. Neuromodulation consists of spinal cord stimulation, deep brain stimulation, and regenerative therapy. We use platelet-rich plasma and prolotherapy. Nowadays, Many of the pain physicians are performing minimally invasive endoscopic spine surgery. So it is a very booming branch. It is exponentially increasing in last 2 decades. If I'm a practical anesthetist, how I'm going to jump on a pain practice? See, you need to have a basic degree in DA, MD or DNB. Then you can go for 1-year fellowships. You have many of national and international options available. You can go for DM pain medicine. Dr. Kothari and Dr. Malhotra has already recited all the options. So I'll just tell you about FIPM. This is conducted by IASP. You have to have a basic degree in anesthesia. You have to enter for an entrance exam, appear for entrance exam. If you are selected, then you are trained for 1 year. A lot of hands-on practice is given in FIPM. So I will encourage the students or residents to join FIPM. Now let's see what is a transition, why transition is important. See, what are the factors in transition? Anesthetist practice is not a OPD based practice as such, but pain physicians OPD is must. Anesthesia practice is a hospital based practice. For a pain physician, a OPD and a procedure room containing SIAM and or sonography machine with resuscitative measures is enough. Communication skills should be at par for pain physicians. The startup cost is little bit more in pain medicine as compared to the anesthesiologist. Team of anesthetist is a surgeon and a paramedical staff in OT and post-operative room. While for the pain physician, he has to take assistance from physiotherapists, occupational therapists, psychologists, counselors, and so many people. Routine of anesthetist starts with the OT and ends in the OT. But for a pain physician, there is a little bit change. He has an OPD and he has a procedural routine. Dependency is a very important factor in freelancers anesthesiologist. Of course, pain medicine, initial days, you are dependent on the consultants who are referring you patients like oncosurgeons, neurosurgeons, orthopedicians, and so forth. But with your vigilant practice, with your hard work, definitely once you settle, you become independent and patient will bring you patient. Anesthesia is an emergency branch, while pain medicine, practically there are no emergencies, so you can enjoy quality time with family and you can give time for the self. The common point in both the branches is medico-legal aspect. You have to be very vigilant and you have to practice ethically. And a fat indemnity cover is required for both the branches. Now let's see the key difference between the patient approach. If being an anesthetist, if we approach a patient for PAC, I will concentrate more on ABC, his comorbidities, what drugs he is taking, what is the position for surgery, and how long the surgery will last so that I can hop for the next call. But for the pain physician, he is more interested in cause of pain, the root cause and disease process. Anesthetist is a facilitator for the surgical intervention and post-op pain management. But pain physician, he himself is involved in the intervention procedure and he is with the patient throughout the rehabilitation. Definitely, the financial rewards are better in pain medicine. Most important thing is appreciation from the patient and relatives. The patient gives you blessings on table. The patient who is in crucial pain, he will smile on table. Take my word. Time crisis is a very important issue for anesthetists, which is not so much for a pain physician. So my take-home message will be, I remember one sentence from Dr. Malhotra. It is one day or day one. For anesthetist who is practicing for a long duration and wants to become a pain physician, it is always one day I will be a pain physician. But for the budding anesthesiologist, if you have inclination while residency days that I want to be in pain medicine, then start from day one and give the nation a pain-free society. Thank you so much, ISA Kalyan, for giving me this opportunity.
Excellent deliberation, Swapna, and very beautiful slides and very well explained. I hope all of us will get motivated now. Now we proceed for the article presentation by Dr. Prakash.
दवेडकर मॅडम तुमचं स्क्रीन शेअरिंग स्टॉप करा. Okay. Am I audible?
Yes, yes.
Yeah. I welcome Dr. Naveen Malhotra and all other dignities, and special welcome to Dr. Kothari for joining us at this last moment for this. It's really great pleasure that Sammohini is also released during this event, and we have been working together as a Kalyan team, and we have all gone through the small things together, and it's really joy that it has reached to such a great height now. So my today's topic is comparison of transforaminal and interlaminar epidural steroid injections for the treatment of chronic lumbar pain. Now, interlaminar is the epidural steroid injections we as anesthetist are all familiar with. So okay. So what's the difference between interlaminar and transforaminal? That's what I'll highlight first, then we'll go for the further journal ready. Now, this journal article is taken from Brazilian Journal of Anesthesiology, volume 67, issue 1, published in January to February 2017. So what is transforaminal epidural steroid injection? Okay, this is a slide. This is a pedicle. In transforaminal, we go below the pedicle at 6 o'clock, and under fluoroscopic guidance, we guide the needle to the once we hit the pedicle, then we negotiate the needle and we reach the anterior epidural space. This is a posterior vertical border, and this is a needle placed in lateral view. This is the lateral view of the fluoroscope. Okay. This is how the contrast looks like, hugging around the pedicle nicely and some part of the nerve view. Here by subpedicular approach, this is a SAP approach where you can see the nerve traversing nerve root and the exiting nerve root. And this is the how the contrast. This is the anterior epidural space. This is how 2 cc of volume can reach to this much height. And this is where our spinal cord lies, where we are most commonly giving blind spinal intrathecal anesthesia. When we give interlaminar epidural, your drug deposition occurs here. So this study is a cross-sectional study, and they compared the 12 months outcome between transforaminal and interlaminar epidural. So methods: the patients who failed to conservative management were subjected to fluoroscopically guided interlaminar and transforaminal steroid injections. Verbal numerical rating scale was used, regularly followed up for 12 months, and MRI findings, complications, verbal numerical rating scale, and satisfaction score were noted. What we routinely use in common in practice is the visual numerical rating scale. Here, the author has used the verbal rating scale. Now, the results: interlaminar epidural most commonly were done at L4-5 level, and there was a significant reduction in verbal numerical rating score in both the groups. Significant differences between two groups. There was no significant difference between two groups as compared to the reduction in the numerical rating scale. And complications were minor in the minor complications were present in interlaminar group, that is 22, amounting to 12.7%, and the transforaminal group 9.5. We'll elaborate this later when you come to the full presentation. The conclusion was this study showed that the interlaminar epidural steroid injections can be as effective as transforaminal epidural steroid injections when performed at the nearest level of lumbar pathology using fluoroscopy in 12 months interval. So the keywords are transforaminal, interlaminar, low back pain, spinal injection, and complications. As you know, that low back pain is the most common, with or without leg pain, is the most common problem encountered today. And you might also see that most of the spine surgeries, they present for the same reason. Prevalence is 60 to 80%. There are many pain generators. One is mechanical compression of the nerve, vascular involvement, inflammation. And when it comes to sleep disk, we say that it's an immunological reaction because the nucleus pulposus is not exposed, means as soon as the immune system forms after our birth, right? So before that only the nucleus pulposus gets encapsulated. So this kind of protein is not exposed to our immune system. So in adult phase, when there is a leakage of this nucleus pulposus, it will create an immense immunological response, and thereby releasing many inflammatory mediators like phospholipase A2, tumor necrosis factor, and also the DRG in special reference has special sodium channels, which are fast sodium channels, which are very resistant to get blocked. That's why steroids are needed to block this channel to obtain a long-term basis, so that with the effect of steroid, they will be made silent for almost 3 to 4 months. And that is also called as, there is a lot of synaptic plasticity occurring at this level. So steroids are used because it's a good membrane stabilizing agent. Now okay. So the mainstay is the epidural steroid injection. Most of the treatment, they give epidural steroid injection. And since there was no clinical data available in Turkey, for the author is from Turkey, and when at that time there were more than million studies going on in USA and UK, so he decided to work on this topic. The techniques for the lumbar epidural, interlaminar techniques for lumbar epidural are the interlaminar, transforaminal, and caudal. These are the three ways where we can deliver steroid in the lumbar region. And as the time means recently there has been a growing trend for the target specific injections. Many of us have noticed that during our early anesthesia periods, we used to receive a patient for interlaminar epidural injection, which with steroid in the syringe, and our job was, yes, we have to give just epidural for this patient. So now also the practice is that they give interlaminar epidural to the patient blindly, as we give for our routine anesthesia practice, and then ask the patient that if they don't have any relief, they can go for surgery. So this area we'll highlight later. And so the author has compared two techniques here between the interlaminar and transforaminal with 12 months out. Most of the studies are there, maximum studies are there with 6 months outcome. So so the author here conducted 12 months outcome. So the ethics committee approval was taken, number was 21245, and informed consent was taken to the patient. So inclusion criteria were duration of the symptoms for more than 6 months. They were failed conservative management, means they did not respond to the NSAIDs or bed rest and physical therapy. And the diagnosis was confirmed by means of MRI. Senior most radiologist was involved in to confirm the diagnosis by the MRI. Exclusion criteria was refusal to intervention, pregnancy, contraindication to intervention like coagulopathy, infection, and allergy. Patients who underwent interventions in other clinic were excluded. Previous lumbar surgeries were also excluded. Neurological deficits or Kalyan syndrome. Now, actually speaking, these are also the red flag signs, some of the signs which we follow during our practice, that whenever a patient comes, if he comes with immediate progressive motor loss, it's better that we don't touch the patient. If he comes with Kalyan syndrome, very few instances we do have endoscopic spine surgery for that. We have done 2 cases with that. But otherwise, per se, it has the whole idea that if the Kalyan syndrome sets in, he has to get operated as early as possible within 24 hours, so that his outcome will be a better one. Yeah, all the patients were examined and reviewed by the author prior to the injection. All their blood profiles were checked. The order of injection was not predetermined. The author just that this patient needs to give. It was left to author's prejudice that he use interlaminar or transforaminal for this particular patient. So root pain generally were given at 1 or 2 levels. If patient had root pain, 1 or 2 levels, then transforaminal was the main mode of say. And if they had low back pain, predominantly low back pain, then interlaminar epidural was preferred. But there was no set randomization of the population. So all injections were given in the same way, blood investigation done, adequate fasting was there. Some same anesthesiologist gave all the injections. All the injections were performed on the fluoroscopic guidance. Prone position is usually used for this purpose. And AP image is used to identify the level. The pillow is provided under the abdomen to negate the lordotic curvature. Standard monitor anesthesia care practice was followed, and local skin, the author has used prilocaine as a local skin infiltration, and sedation was given with midazolam and fentanyl. In practice, we don't use sedation as such. We usually do under local anesthesia. IPEF, there is a transforaminal technique. 20 gauge blunt curve needle from Epimed was used. Subpedicular safe triangle in oblique as showed in the first slide. Then final needle position was confirmed by dye spread, and 80 milligram of triamcinolone was used with 0.25% silsorcan. Vascular spread, if there was vascular spread, the needle was adjusted. Single level 4 ml of the mixture was given, and multiple level 2 ml at each level. He has not mentioned whether he has given bilaterally or unilaterally, but in clinical practice, whenever we do, we always do at single level bilateral. Only if the patient has specifically complained on unilateral root pain, then we go for unilateral injections. Total dose of steroid was constant. Even if you have to give at 1 level or 2 level, the dose was 80 milligrams. That dose we divided to either 4 ml or 8 ml. That's what we do in routine practice also. If you want to give it to 4 levels, the total dose will be same. 40 milligram is what we do in routine practice, because we follow that in a year, patients should not be subjected to more than 240 milligram of triamcinolone acetate. So for that, even if the patient needs either cervical or lumbar at the same time, the dose is always the same, 40 mg. Only that dose is adjusted. In interlaminar epidural technique, 18 gauge TE needle was used. Air resistance, loss of resistance technique by air was used. And if failed to reach the midline approach, paramedian approach was used. And in interlaminar, they use 8 ml of the solution, 80 milligram of triamcinolone, and 3 ml of 0.25% silcer. So post-procedure, all patients were rested on table for 5 minutes. Then they were shifted to recovery room for 2 hours. They watched for the complications, and if patients were comfortable, they were made to walk and assess their pain relief. And discharged patients were asked to report immediately in case of any unexpected events. Follow-up was done at 1, 3, 6, 9, and 12 months. In a clinical practice, what you do is generally the patient is discharged on the same day. So next day we ask the receptionist to give them a call as to how they are feeling, and ask them to, because since it is a steroid, usually the action sets in by 3 to 10 days. So we ask them to visit after 15 days to assess the amount of pain relief, and then 1 month, 3 months, and 6 months follow-up. This is what we do clinically. Now, relief, ENV score, and complications and MRI findings were recorded. ENV score, the slide will come later on, and the modified North American Spine Society score was used here. Now, this is the modified North American Spine Society patient satisfaction score. Score 0, that is bad, or no change of complaint, or even worse. Moderate means epidural steroid injection help, but I won't let this procedure again. Good, that is most complaints were relieved, and I would like to let this procedure again if my complaints reappear. And perfect means epidural steroid satisfied me and fulfilled my expectations. So statistical analysis was done by program SPSS version 15 for Windows. Kolmogorov-Smirnov test was used for demographic data distribution. Chi-square test was used for compare statistics satisfaction indexes and complication between the groups. The parametric test ANOVA by analysis of repeated measures were used for ENV scores pre and post procedure. And the student's t-test for independent samples, differences in pain reduction between the 2 groups. And the data was expressed in standard deviation. Findings. The total number of patients are 364 between April 2013 to October 2014. 23 did not attend hospital. 23 patients did not attend the hospital. 1 patient refused to intervene on the operating table. 6 were lost to follow-up, and 36 had previous medical history of lumbar surgeries. And patient with complete data was 299. So distribution according to month of post-injection follow-up was first month 299, second month 238, third month 211, that is 7.76%. 6th month, 9th month 171, 12th month 114. So 299 patients include 485 interventions. That means there were repeat injections also. What we do in clinical practice is that we always advise them course of 3 injections. But then depending on this, most of the time, 90% of them doesn't require a second injection per se. So transforaminal technique group consisted of 126 patients with 266 injections, including the repeated injections. And the interlaminar technique group consisted of 173 patients with 190 injections. So mean age, mean was 54 and range was 23 to 85. Mean age was 54. And the demographic data had no significant differences between the 2 groups. So this is a slide of the demographic data. You see that the patient who received interlaminar epidural steroid injection, the mean age was 58, while in the transforaminal group, the mean age was 51. And weight was almost constant, almost the same. Height was also no much difference. Number of injections that was according to other choice, and pain duration means all the patients had almost 2 years of pain, not responding to any previous surgeries. Okay, the MRI findings, they found that most affected levels were L4-5. Only disc pathology was seen in almost 144 patients, and degenerative alterations in 64 of them. There was diffuse degeneration in 125 patients. Spinal of that spinal stenosis was associated with 73 number of patients, and hypertrophy of articular facet zone was seen in the 27. This shows that with increasing age, the amount of disease morphology, the disc morphology changes. We'll come to that. Sure. Yeah, this is now basically there was this disease was associated with disc bulging, disc protrusion, and disc extrusion. There were no reported cases of disc sequestration in this series. Okay, and as you see that most of the cases were then at the L4-5 level. And the incidence of disc bulge increases with age. So in from 4th to 5th decade of life, if you take an MRI of asymptomatic patients also, you can see many disc bulges in them. So we have to really clinically ascertain whether those clinical findings are correlating with the MRI findings in the patient's communities. So and L4-5 was the most injected level in both groups, and the number of repeated injections is given. In transforaminal, 26 patients were receiving single level injection. At 2 level was done in around 70 patients, and number of first injection was repeated, and the repeat second injection was fewer. The same way in interlaminar group, there were fewer second repeat injections. So most of them in both the groups have only twice, maximum they have has to be repeated twice. So this is the ENV score, mean pre-injection score for IPL group was, interlaminar group was 7.8, and in the transforaminal group was 10.6, but statistically not significant. But we see that all the patients had observed a decrease in the VAS, significant decrease in VAS at first month, although there was a increase in the VAS score, but patient satisfaction score was high, and it was common in both the groups. No catastrophic complications were noted. Interlaminar group has 22 minor complications, and transforaminal group has 12. that will be elaborated in the next table. And during the therapy period, 3 patients from the interlaminar group and 8 patients from the transforaminal group underwent lumbar surgeries. Okay. So what are the minor complications? The dural puncture in the interlaminar group was 4 and almost 3 in the transforaminal group. Post-dural puncture headache was not seen in the transforaminal group, but in interlaminar group they had 1, and that 2 was needed blood patch therapy for relief. Subdural block was seen almost same incidences, but it was around 1.7% in the interlaminar group and 1.5% in the transforaminal. Transient paresthesias were more in the interlaminar group. Hiccups, menstrual irregularities, and vasovagal reaction was seen in the interlaminar group. But vasovagal reaction is not only related to interlaminar group. We have also seen in this particular study, the author has not seen the transforaminal group. It can be seen anytime, and we have seen quite a few times especially during severe pain. They definitely will have the vasovagal attack. That's why we always keep an atropine, loaded atropine syringe always ready with IV access to the patient whenever we are doing transforaminal approach. Okay, so evaluate and compare. The whole study was designed to evaluate and compare the effects of interlaminar and transforaminal steroid injections with a 12 months follow-up in all the patients with chronic low back pain who have failed conservative line of treatment. What are they? They are basically NSAID, hot or cold fomentations, physiotherapy, bed traction, and bed rest. Okay. So pre-procedure analysis of patient information, there was no statistically difference. Mean age in interlaminar group was more than the transforaminal group. ENV scores, the interlaminar group has more reduction than the transforaminal group, but there was no statistical significance. MRI results there was no significant difference. There was significant decrease in the ENV scores in both the groups, correlates with the increased satisfaction rates. 85.1% of the treated patient improved. Symptoms worsened in 13.9% who classified their condition as poor or they were not satisfied with the injections. Now, there was a recent study conducted in 2010 where the interlaminar injection, he found an interlaminar injection was provided superior relief, 92%, as compared to transforaminal, it was 90%. But the condition worsened. Number of patients whose condition worsened in the transforaminal group was 9.5%. So they found that interlaminar group was more significant, have more profound relief. But both provide largely good pain relief, and ENV score comparison was not statistically different, and higher satisfaction rates due to proximity of the injection pathology. And interlaminar was preferred in elderly due to multiple pathologies. The present study is also important because as compared to both the groups, they presented similar and high level of satisfaction, and which may be due to the effective fluoroscopy or proximity to the site of injection. We are used to, most of us are used to give interlaminar epidural for anesthesia purposes, and sometimes when the orthopedician requests us, we do give them the interlaminar steroid. But it's always better if we give near to the site of pathology, because at that time when we give, we don't know what is the condition of the patient, what are his complaints, which side the MRI findings are done, and we just give on request. Okay. So in 2002, there was a study by Wang et al. Who conducted a study with 69 patients with symptomatic lumbar disc herniation, and in follow-up after epidural steroid injection, root pain was reduced. He had a follow-up of almost a 2-year follow-up, and surgical intervention was avoided during this period. Now, the advantage that our study has that it has more sample size is almost double. Okay. So in 2007, Ackerman compared all the 3 lumbar approach, interlaminar, transforaminal, and caudal, and he claimed that the transforaminal was most effective. But 13 of the transforaminal patient and 12 of the IPL patient were not satisfied, and the group size sample size was 30. Okay, so in our study, no significant difference was observed because difference was observed, and the sample size was more, and both were given fluoroscopically. So in 2006, Sheffield et al. They found that the transforaminal group has more superior to the interlaminar group, but then the sample size of just 20, and age of the patients were not known, and similarity was steroid was injected at same level as the only similarity between this group and our study was that steroid was injected at the same level of pathology. Our author had a large number of sample size. In 2004, Butterman compared surgery with interlaminar epidural steroid for large interval disc herniations, more than 25% sectional area of the vertebral canal. And they found that effective interlaminar epidural did found effective treatment in almost 42 to 56% of the patient, and temporary pain relief was there for 6 weeks prior to surgery. In 1995, a review study was done by Coes et al. He reviewed 8 random studies evaluating the efficacy of the interlaminar technique in herniated disc, sciatica or radiculopathy in the lumbar spine. 5 were positive for short-term relief, and 1 study was positive for the long-term relief. Now, in these studies, remember that it is the year of 1995, and availability of CM was a big issue. So, the technique was done mostly blindly. In 2003, Boswell et al., who published a study on the interlaminar epidural, he reported absence of long-term side effects. No large number of studies. There are large number of studies on the transforaminal interlaminar epidural. Either they are positive or negative, but more or less with more than 6 months of efficacy. And there is also so that suggests that epidural steroids do have a role in management of back pain. Okay, and in interlaminar epidural randomized controlled blind study, 70% was the success rate. So we can increase, as shown by our study, if we do it under fluoroscopic guidance, definitely the success rate will be close to 90%. So Hopwood and Abraham describe 33 factors associated with the success rate of epidural steroid injection. But the most important, they found that professional who does the procedure remains a very important factor, and that influences the other success or satisfaction rate. The other factors being the age of the patient, the disc level, the duration of effect, the habits like smoking, alcohol, and osteoporosis. All these factors, whether they are anemic, there are multiple factors, and this is one of the important ones. So, in a review conducted by Parr et al., interlaminar was done without fluoroscopy. Recently, transforaminal was done under fluoroscopy was preferred, and injection near the site of pathology. In our study, both of them were done in fluoroscopy guided, and the drug was deposited near the site of pathology. So fewer complications were observed in the transforaminal group other than in IPL group, respectively, and serious complication requiring hospitalization was not observed. The only patient with the durometer in transforaminal, so durometer can be perforated regardless of the proper needle placement. But remember here the needle size is small, whereas in interlaminar we use a 2A needle 18 inches. So definitely that will make a difference. Subdural intrathecal spread, that depends on the contrast study. So you should be aware of how the contrast spread looks like when it is subdural or intrathecal. So in intrathecal spread, it will be distributed evenly and large over a large area. Okay, and in case of vascular, when you inject, you will not see any dye. So as soon as you inject, and if you don't see any dye spread, that means you're sure that it's in the vascular. And the only other thing, important thing is that in arterial, you will not see any dye spread, but whereas in venous flow, it will be a flow. The second time you click the shoot, and the dye will be managed. So that's the difference. That is the time lag between the venous and the arterial spread. So you have to be careful regarding that whenever you are doing fluoroscopy guided steroid injection. And as compared to the anterior artery syndrome, fortunately, all the disc pathologies are present at L4 or alpha level, whereas this anterior artery is present only at maximum at the L2 level. So below that, there are very few incidents. So that is also avoided. So in the transforaminal group, the dural puncture was strict, but there are no reported headaches. While the interlaminar epidural, there was one dural puncture which needed to be required to be treated with epidural blood patch. And with interlaminar epidural, the subdural injections are almost 0.85%. So to recognize the possible dural puncture, interventionists need to distinguish the pattern of intrathecal, subdural, and epidural contrast. But epidural, you feel a ground, a small bubbles in between that spread. And Goodman et al. Reported complications resulting from dural puncture in the transforaminal, particularly during subdural injections. But many of these were underreported by the practitioners, which is the main issue. The whole essence is that you should be aware of how the dye spread looks like and which dye you are using. We commonly use Omnipec 350 milligram or 250 is also available. If that is good. Otherwise, if you don't have dye, you can also use the dye which are used by the IVP radiologist dye who uses IVP. So that's also amount to 350 milligram percent that you can use, but never use urography, which is used for the renal procedures, because that is 750 milligram percent. Okay, the strength of our study was that same professionals did all the intervention and all were fluoroscopically guided. There was a large population size. Limitation, there was selection bias because there was no randomization as per he just when he thought that he used to do transforaminal, he gave transforaminal. And there was memory bias. He didn't remember which patient he had done this much transforaminal lamina. Incomplete data. As I said, not randomized. Heterogeneity of the group and evaluation of overall specific function of the spine in addition to EMV score would be a better method to qualify any difference in groups. We need more other scores which can qualify which will help in differentiating the amount of relief or the quality of life the patient has improved. Like for knee pain, we use OMAC scale, which has not only pain but other activities also, and hence we are able to justify which intervention suits the patient the most. The similar type of intervention needs to be scale needs to be there for the spine patients. So conclusion was advanced age can increase pathologies at various levels that aggravate low back pain, but there is also saying that as the age increases, the number of non-pathological disc prolapse are higher. So if you see a 60-year-old patient, MRI 60-year-old patient, you see multiple disc bulges. So that doesn't mean that he has pathology at all the levels. This is very important because I'd like to share one case where she was a 60-year-old lady and her son was a GP and she used to have severe back pain. And of course, whenever we took her MRI, she had multiple disc prolapse at various levels with facetal atrophy and all those things. And she was advised surgery all the time. But with her age, they did opted for surgery. But her complaint was very difficult. She could not get up from the sofa, which was little bit less height than the other thing. So she had to couch a little bit. So whenever she used to sit on the sofa, getting up from the sofa was difficult. Otherwise, her activities were not limited. So what we did was, we did a diagnostic median branch block in her case. And we found that she had relief with a simple diagnostic median branch block where we had used sensorkin as the agent around 0.3 ml at each level. And she had very good relief for 1 month. For 1 month, she was totally pain-free. All her activity, she was able to do pain-free. And after 1 month, she complained back again with the same pain. So then we did radio frequency ablation of that, so that the duration of her pain relief was improved. And till date, she didn't have any pain after that. So it's not necessary that whatever you see on the MRI it must be treated. Okay? So, however, more random studies comparing the two techniques have done under fluoroscopy at the level closest to the lumbar pathologies are needed. So here also the interlaminar were done, but those were done under fluoroscopic guidance where it was observed whether the dye spread was adequate or not. That was one of the most complex thing, because we also see that during our routine anesthesia practice also many times we get patchy anesthesia, because as such they mentioned that there are septic formation. We don't know whether there is a vessel, any aberrant vessel, so which will take up the dye. So it's better that you do under fluoroscopy to see any vascular presence. Secondly, and to note the spread of the dye, whether it is going to the required level you're doing. So even if you want to do interlaminar, it's better to be done under fluoroscopic guided in prone position. The author declares that there are no conflict of interest, and the author critically reviewed the manuscript for important intellectual content and approved the final manuscript. This study has no sponsorship or external funding. Really, I appreciate him because he just not only added the numerical rating scale, but also made sure that he had a satisfaction rating scale also for this patient, and he had done a lot of literature search to see what was effective and what were the fallbacks of the interlaminar which was done in those studies. And he tried to correct those things, like use of fluoroscopy guided for interlaminar epidural. He observed and he kept a long-term follow-up for 1 year, and then he got the results. So these are the references. More such studies are needed. The take-home message is that whether you give transforaminal epidural or interlaminar epidural, make sure that if you are giving it, you know what are the patient's complaint and what level the pathology exists for them. Okay, and if you want to give, you are giving at the level of nearest to the pathology. Okay, there are many cases which will with back pain and no leg pain, where other things are also important, like facet, the SI joint, and the osteoporosis. Because I'll tell you one case where not young, 60-year-old male presented with low back pain. Okay, and his MRI finding was absolutely normal, and there was no disc bulge, nothing for it. So then I did his DEXA scan study. I found that his DEXA score was -3. Now osteoporosis is -1, -2.5. More than that is osteoporosis. His score was -3. And the moment we start him anti-osteoporotic treatment, his pain totally diminished. He recovered completely. So that is the essence, that this pain, back pain, low back pain, can be due to multiple causes. Okay? So it's better that you evaluate and come to a conclusion at what is the cause of his pain, and then only you go ahead either with whatever familiar you are, but that go under fluoroscopic guidance, either transforaminal. If it is transforaminal, the other advantage is that when we give transforaminal, we also give a normal saline wash of 5 ml at each level. That does two things. That firstly, it will dilute all the irritants from the DRG, which is very important because DRG is highly irritable. If you remove all the inflammatory mediators from that, then the amount of pain relief the patient gets or the duration will be longer. Second thing is, when you inject 5 ml of normal saline, you also come to know as to how is the canal, whether it is really tight or not. For example, patient with real canal stenosis will not withstand even 2 ml of the normal saline. He will start having tightness, that is paresthesia over there, and gripping pain. That will subside once you give the local anesthetic. Now, this is different from the pain which is intraneural. Intraneural pain, patient will howl in pain. He will not tolerate even 0.1 ml of it. Okay. So that's the advantage of giving transforaminal. Somebody has my phone. Okay, and the other thing is, whenever you do transforaminal, suppose it is unilateral. If there is a now this study doesn't mention about sequestered, but we have found that in 2 or 3 patients with sequestration which came to us, that in sequestration the main thing is that the inflamed nucleus pulposus material is in the epidural space. It is definitely bound to get cleared. But when we infuse normal saline over that, around 5 to 10 ml, it will wash off of the irritants and help in recovery much faster. So that way also, when you give transforaminal, you are really in the anterior epidural space, as I shown in the last slide. I'll show you once again. Yeah. This is how a transforaminal will look like. The dye is hugging around the pedicle, okay, nicely, and this is the anterior epidural space where the dye is formed. So this is really very near to the site of pathology or issue. And what we do, what we achieve by doing this is we give the patient a time-free period, pain-free period, so that they can rehabilitate, so that they don't have to they don't have to undergo the trauma of pain. So that will itself help their body to rejuvenate. That is one thing. Secondly, we can it will, once they get a shock, nahi abhi pain hai, so they will do a good amount. They will take care of the back. Okay, back is such a thing. If you don't give attention to it, they will one day give you one झटका कि नहीं अभी इसको ध्यान दो. So the core strengthening is the mainstay in this. But for that to do that, you need to give them pain-free period. So that's what we achieve with this. Even so, if the duration is for 6 months and the patient is able to do a good amount of core strengthening for himself, which itself will take around 6 weeks. For once he starts the exercises, the core strengthening exercises, the results will be obtained. He can assess only after 6 weeks, because that's the normal healing time. So we definitely provide relief with transplant till that time. So that's what our aim is, that we provide a pain-free period so that the patient get to have a rehabilitation and thereby prevent further surgery. And this is the giving transforaminal or interlaminal epidural. It's the only, my sir always says, Dr. Kothari always says that this is the only chance the patient has to avoid surgery. Because after this, if he doesn't get relief, the other thing is surgery. So whenever you transfer an epidural steroid or interlaminar, make sure that you don't end up prospective guidance. You are knowing what you are doing, where you are giving, and what references you obtain from this procedure. That's all. Thank you.
Excellent presentation, and so much in detail and perfect, and telling us timely about what we should do in our clinical practice, and even very rightly take back home messages. Prakash, would you like to show us the videos also, so that we can ask Dr. Kailash Kothari to comment and share his views later?
Yeah.
So we can proceed, and then we'll have together the comments.
Okay.
Yeah.
I'm very lazy at making videos. So what I did is I just made a PPT and then shared some videos of the patient. I'm sorry about that. See, now this is the case where we are giving sympathetic block to the patient. Now this is a patient, is a cancer patient with colon cancer, but then he has mets at the lumbar region and a bogious pain up till the epigastric region. And he was howling in pain, not responding to any other treatment, morphine. Morphine was out of question because he was having multiple strictures. So morphine was out of question. So we posted him for splanchnic. Splanchnic, the advantage is that we can give less volume in a confined space. So this was done at the thoracic level. So we made the CM little bit oblique, around 15 to 20 degree oblique, and then place the needle under direct fluoroscopic guidance, and we make that the needle reach at least the middle third of the vertebral body. Now, for here, since we have to go oblique, we use long needle, that is 22 gauge, 15 centimeter needle are available. Those are also called as the aspiration needle. Now, this is the vertebral body shadow, this is the pedicle, and these are the facet joints. Okay. So here we can see the contrast spread hugging nicely to the vertebral body. Here, nicely to the hugging. Contrast is hugging nicely to the vertebral body. So whenever you give sympathetic block, splanchnic block, one thing sure that the dye should be well confined to the fascia. So this is how it is looking like this. And this patient had immediate relief of pain. So that's what is. Okay, so what we have mentioned here is the ENV scale, or the visual verbal numeric rating scale. Kitna takka farak hai? That's what we commonly use. When the patient comes to your OPD, we use the with the smileys. That is called as a visual numerical rating scale. And but what happens is many times patients are not able to tell. We always ask them, रुपए में कितना फर्क है, 100 में कितना फर्क है. We ask them to say number. कुछ नहीं तो 4 आना 8 आना 54 कुछ तो फर्क बताओ. Because sometimes the patients are really very confused. Means they always tell 10%, but when you ask in detail, they'll say नहीं ये relief है, ये relief है, ये relief है. So it's arbitrary, but still it will serve the purpose that the patient is amount of relief. Now the next case we did yesterday only. Now this is a very unique case because initially what happened, orthopedic when he called me, he said that we have 3 level fractures and there is retropulsion. So I said, if there is retropulsion, we are not going to do vertebroplasty, that's for sure. Then after some time, next day he sent me the MRI picture. Now on MRI, what I found was that this D11, we see the whiteness, that means it's a chronic fracture. And chronic fracture with slight retropulsion. So retropulsion was not acute one, it was a chronic one. So we didn't need to worry. Now this patient has a fracture, she had a fall. Okay, she was 65 years old, she had a fall, and after fall, she developed fracture at D12 and L1. Now L1 was already fractured before, but she had a secondary fracture at the, again the L1 was fractured here. So we need to address both of these, because if we don't do this, and if the D12 collapse occur, then the ultimate pressure will be on our spinal cord and should have, after 1 month, should require a surgical debridement with implantation. Now, and plus at that time of fracture, she was unable to turn in bed, sit for a longer time. Those were the, means her pain was unbearable. That was the other factor. And plus the impact that she will a probable candidate for surgical implantation here. So since the moment I came to know that this is an old fracture with a slight retropulsion, I was quite sure that we can do vertebroplasty here perfectly. Now in such cases, our aim is not to increase the height of the vertebral border. Here also, our aim is to stabilize the vertebra as it is. Okay, so hardly 1 ml of cement, if it goes and settles there, then our job is done. So that we first see how osteoporotic she was, that it was barely visible. Okay, her score was, I think, -4 BMD, that is bone DEXA score was -4. So what we did is, first we gave local, we put in spinal needle up till the pedicle, and then we assess the direction or depth in the lateral view. So we confirm that the level of vertebra we are doing here, this is D11, this is D12, which is slightly collapsed, and this is L1. Now here the point, L1 is already collapsed this much. That means it is a chronic fracture. But then the MRI was showing edema. That is very important thing. So in vertebral fractures, we see that if MRI is showing edema, that means the fracture is a recent one, and if patient is having severe pain, we cannot just give bed rest to the patient, because with that we are inviting a host of other complications like deep vein thrombosis. We have a patient, since we had a patient who was there only for 5 days. She was also same vertebral compression fracture, but somehow or other she was there bedridden for 5 days. And we did a procedure, and after 2 days she developed pulmonary edema. So some patients, these vascular complications can develop very fast. So it's very important, necessary that they should be mobilized early. And in that way, vertebroplasty is really a rewarding procedure where patient is able to tell you the benefit instantly. Now, this was the first procedure when I attended my first pain conference, Global Pain Update. At that time, I saw this procedure. Means last minute they used to show the videos of the procedure. So that time I saw this procedure. And today, when I did the patient, I realized the amount of satisfaction she got and the relief she got. And really satisfied. Yes, this is really a thing which a pain physician can do. So once we give a local, we make sure that we inject local up till the periosteum, because periosteum is the most sensitive part. So after that, we use a special 18 gauge needle. Now, there are bone biopsy needles are available, but the advantage is these needles, they are sharp needles, and we can make the placement really very easy. So here, under continuous fluoroscopic guidance in AP and lateral, both AP and lateral view, we make sure that we reach the anterior 1/3 of the vertebral body. Okay, to ensure that we is there perfectly. And at the same time, in AP view, we make sure that we are in the midline. So that means there is no need for the other needle to be placed. So if you have placed this needle in this way, where the needle is in lateral view is in anterior 1/3 and in AP view is in the midline. That means with one single needle injection, your dye will be going to spread to the both the sides. And that's what we see here on table at the D12 and the L1 level. L1 level, I was able to inject only 0.5 ml of the cement, but even that was enough to spread bilaterally, as you see here in the post X-ray. And the contrast has reached to the middle third. So we had, of the 3 pillars, we had made that 2/3 of the pillar is strong. So that will provide enough relief for the patient. And if we inject minimal cement, we prevent most of the complications associated with. And this is her response after surgery. Just oh.
It's not moving.
Not moving, yeah. Yeah, be happens.
It's okay.
But both your patients are looking well contained and not in pain.
Yeah. No, that is now it will not be able to, because first I have to go to the technical issue.
Yeah, excellent video and your PPT presentation, very well explained. And now we'll wait for, which we were eagerly waiting for Dr. Kailash Kothari to comment and his views. Sir, Dr. Kailash Kothari, sir.
Thank you, Dr. Sanjay Bapade. And I think both presentations, they stress that whatever you want to do, whether it is anesthesia, critical care, pain management, training is essential. So once you have good training, you can do justice to what you are doing in your life. So what Dr. Prakash was showing, it is all uske experience or uska training ka nichod hai. So see, there are a lot of things you can do with if you develop good skill over time. So I think the scope of pain practice is right from a simple medical management of a back pain to a headache, or maybe a simple cancer pain, which you can manage by simple medication, to a very, very complicated, very advanced procedure, or so you can say surgery, minimally invasive surgery for those patients. So there are a lot of things which are available in pain management. So as you know that we used to give anesthesia to patient, assisting surgeon and making surgeon's life easy. Then we became physicians. We took over the intensive care from people, and now we are taking a lot of work from other surgeons by developing our own skill by our newer methods. So there is a lot of growth, a lot of adornment by other specialists. They do refer us, they do need our help as we need theirs. So as Dr. Dayavadkar said very correctly, that it is one of the very coolest branch with independent practice satisfaction. And of course, to achieve that, you have to do a lot of hard work. It is not a part-time job. It is not a like you chalo 2 ghanta anesthesia ka time mila to pain management kar lete. No, that is not. So what Prakash said, that I always tell him that if you do one wrong procedure or you don't do it correctly, you push that patient towards the surgery, major surgery, and for which he may have complication which he can be on the bed for forever. So you need to give your 100%, do the thing properly. And even if you don't get result after doing the procedure correctly, it's okay. But if you diagnose properly and do the procedure correctly, then most of the time patients are very, very happy, and you can really relieve those patients. So it's a very novel branch, and I hope more and more anesthesiologists become pain physician in future, especially newer students who are still in their initial phase. They can think of pain management if they are interested in regional anesthesia and pain management. They should do proper training and come in. So thank you very much for inviting me, and excellent talks. Both the talks were excellent, and it was nice to meet Dr. Naveen, Dr. Kala, and everyone here. Thank you very much.
Thank you so much, sir. You were such a blessing, and you have shared many ideas and what one should be doing. And would Dr. Naveen Malhotra sir also want to share something and about the presentation today? Dr. Naveen sir.
I echo the words to Dr. Kailash. Good presentations by both the presenters, and definitely Dr. Prakash talked about the practical aspects of the comparison. And it was all the aspects in the study were up to the how the research should be done, and it was a very nicely conducted study. And results were also honestly represented that interlaminar at times is as good as transforaminal, and the videos are also good. So it's pleasure, and I hope the Kalyan branch keeps on doing more such CMEs, especially on chronic pain. So that will be very good.
Definitely, sir.
For I have a point to make here. For interlaminar and transforaminal, it doesn't make it doesn't need what route you are going through. Under fluoroscopy, you need to see where the drug is going. If your drug is going at a right area, whatever route you take, whether you put interlaminar and they put catheter in the foramen through the interlaminar, it's okay. If your drug and dye is going in that area where the compression is happening, you will get the result.
Yes. Thank you so much, sir. Anybody from the audience would wish to ask any questions? We have experts here on pain management. And anybody from the audience? The office bearers, Dr. Manisha Katikar or Avinash Bhosle, sir, would like to share something? I think the presentation and your talk were so much lucid and so much in detail that everybody looks so content. And even there are no doubts and no questions. Even the videos and PPTs were very self-explanatory, and Prakash had made efforts every time telling us what the clinical practitioner should do and how it was little different from the article presentation. So I think if everybody is satisfied, anybody would, yeah. So like I'd like to thank Dr. Naveen Malhotra sir, ISA National Secretary, the leader of pain medicine. And also I'm very thankful to Dr. Kailash Kothari sir for conducting this session. And he's the president of Indian Society of for the study of pain. So we were very fortunate to have these two main stalwarts for our discussion today. And I also thank our office bearers to be present: Dr. Manisha Katikar, President, Secretary Avinash Bhosle, Vice President Dr. Anjali Bhure, and GC member Dr. Ashok Deshpande, and the audience, the participants, the sponsors, and Janeka, who has given us this platform. And thank you, everyone. Smita, would you like to say something, or Kalas?
No, I think Kala
had some emergency.
Yeah,
you're there, Kala. You can, you can take
I'm really
over.
thankful for Dr. Kailash Kothari and Dr. Naveen Malhotra sir for accepting the invite. We are such a small branch growing slowly, but they really obliged us with their presence.
Yes.
And all my ISA Kalyan family, very thankful for all the support and the participation, and all of them came forward today. Just everybody registered, and so much of contribution towards bulletin Sammohini too. And I thank the editors from the bottom of the heart. They really did very well job. And Avinash Bhosle for being present throughout, and Maharashtra State ISA for giving us this Jenica platform, which is free of charge, and they take a lot of trouble to make the flyers, make the links, and etc. Thank you so much. All the sponsors also for the e-bulletin, Troika, Torin, and Varanium. Thank you so much. Dr. Smita, madam, do you want to?
No, yeah, we can conclude now. You already spoken everything now.
Okay.
Very much.
Dr.
Thank you.
Kothari, Dr.
Yeah.
Thank you, Kala. You said
Dr. Naveen?
Kalyan branch is very new, it's developing. I know Kalyan branch since 1999, 2000, when I came with Dr. Gedu. That time also
Yes.
it was very vibrant, very progressive, and it's one of the most dynamic branch. So
Thank you,
Yes.
sir. Thank you so much.
You are leading the
I have had the pleasure of being associated with you, sir. I did so many cases in the beginning.
Dhari is right. You should not say it's a small branch. It's a small dynamite.
Yes.
Thank you so
Thank you
much.
so much.
It's coming from you, sir. It's a big
Great
thing for
compliment.
us. Yes. Thank you so much, sir. We
Thank you
end
so
this.
much.
Have a
Yes,
good
yes,
day.
yes. Thank you
Thank
so
you,
much.
sir. Thank you.
Thank you.
Thank you so much.